Yes, your screen is visible, Dr. Sandeep.
Okay, thank you. So I'll start. Okay. So the first task is regarding the India Newborn Action Plan. So the India Newborn Action Plan was launched in 2014 as part of India's efforts to align with the DASH. It's a part of India's efforts to align with which international program that was launched by the World Health Assembly in the same year, that is June 2014, so as to avoid preventable neonatal mortality. Yeah, so I got some answers. Someone has told ENAP, that is Every Newborn Action Plan. Okay, so it was part of India's response to the or India's commitment towards this thing to avoid preventable neonatal mortality, and based on that only, in the same year, India also launched the India Newborn Action Plan. So, what were the two specific goals under the INAP? What were the two goals for which this was introduced? Yeah, so one is to achieve a single digit NMR. What else? Okay, this was one of the goals. So one is to achieve single digit stillbirth rate, and one is single digit NMR. So these were the two goals under the INAP. Okay, then there were 6 pillars of intervention under the INAP to reduce the preventable mortality. So which were those 6 pillars under which the interventions were planned? Still no. Okay, then I'll discuss. Yeah, so it is preconceptional and antenatal care. Yeah, so care during childbirth, care during labor, NICU postnatal care, right? Right. Then next is, what are the 6 key principles that guide INAP? And go on to the next question, and then we'll discuss the answers together for all the 5 of them. Sorry. And the interventions under the INAP are divided into 3 categories, so as to account for interstate and intrastate variations in the healthcare infrastructure. So which are those 3 categories in which the government has divided all the interventions? So I'll move on to the answers. Slides are- So answer to the first question is every newborn action plan. The second is the two specific goals were to, by the end of the year 2030, we have to achieve a single digit NMR, and individually all the states should achieve single digit NMR by the year 2035. And also we have to we have to end these preventable stillbirths, and we have to achieve a single digit stillbirth rate by the year 2030. And all these states individually should achieve the same target by 2035. Okay, then the 6 pillars of intervention were preconception and antenatal care, care during labor and childbirth, immediate newborn care, care of a healthy newborn, care of small and sick newborn, and care beyond the newborn survival. The 6 principles were equity, gender equality, quality of care, convergence, partnership with NGOs, and accountability. And the last is there were three categories. All the interventions under this INAP were divided into three categories. One is the essential interventions, which have to be done at all the health facilities. Situational, which may be needed at certain facilities depending on the local circumstances, and advanced, which may be available at certain higher referral centers. Okay, so this was about the first OSCE. I'll move on to the second one. So it is a case scenario. A baby X, who is a female child, was born SGA and IUGR, delivered at 38 weeks of birth, 38 weeks of gestation with a birth weight of 1.8 kgs to a G2 P0 A1 L0 mother. And the baby was admitted to NICU for respiratory distress and CPAP support. On examination, the child was edematous. The sepsis screen was sent, which was negative, and within the first 72 hours of life, the baby developed hypoglycemia requiring glucose infusion, coagulopathy, which was manifesting as blood-stained Ng aspirates, and there was significant jaundice requiring phototherapy. Now, the investigations they revealed deranged liver enzymes with high serum ferritin of around 900 nanogram per ml, and also a raised serum alpha fetoprotein around 2.5 lakh nanogram per ml. So this is the case scenario. The first question is, what is the most probable diagnosis in this scenario? Yeah. So it is neonatal hemochromatosis or GALD, that is gestational alloimmune liver disease, right? Yeah. So what is the most probable pathophysiology of the disease? So it is usually because of the IgG antibodies which develop because of the sensitization of the mother towards the fetal hepatocytes. Okay. And we'll discuss all the answers at the end. Then how do we confirm the diagnosis? So based on the clinical picture, it looks like GALD. But then what do you want to do to confirm the diagnosis? So yes, one is the lip biopsy, and you want to demonstrate the iron deposition, extrahepatic hemosiderosis in either a lip biopsy or what else? You can go for a T2 weighted MRI. Okay. To demonstrate extrahepatic iron deposition. And what are the treatment options for this disease? And what is the risk of recurrence in subsequent pregnancies? So, treatment options, yes, one is IVIG. Other than IVIG, what else? Liver transplant remains the last option, but you have one thing in between, or rather before IVIG. You can go for exchange transfusion. Okay. And what is the risk of recurrence in the subsequent pregnancies? So I'll tell the answers. Okay, so the diagnosis is, as you told, it is neonatal hemochromatosis. It occurs mainly due to the aluminization because of the sensitization of the mother to fetal hepatocyte antigens and IgG antibodies, which are thus produced, they will cross the placenta. And the diagnosis can be confirmed by demonstrating extrahepatic hemosiderosis, either of the two ways. One is oral tissue biopsy, which demonstrates iron deposition, or a T2 weighted MRI to demonstrate the extrahepatic iron deposition. The treatment options include exchange transfusion, and it may be followed by IVIG 1 gram per kg to block the antibody-induced complement activation. Liver transplant remains the last option. Okay. And the risk of recurrence, of course, there is a high chance of recurrence, almost 90%, and there will be increased lethality in each subsequent pregnancy. So this has to be explained to the parents, and there is always, there have been studies now which have shown that IVIG can be given to the mother in the antenatal period, so as to decrease the severity of disease in the baby. Okay. And coming to the third OSCE, that a sub-district hospital, which is having a 12-bed SNCU attached with it, decides to set up a facility for helping the mothers with lactation. Okay, so The first question is that as per the national guidelines for lactation management centers and public health facilities, this sub-district hospital is eligible to start what level of lactation facility in order to provide the lactation support to the mothers. So as per the national guidelines, this thing for setting up the lactation centers in public health facilities, there are three things which we can set up. Okay. One is a lactation support unit, which would be set up which has to be set up at all delivery points. Okay. Then sub-district hospitals or level 2 centers can start a lactation management center. Okay. And then the medical colleges or tertiary care centers, they have to start a comprehensive lactation management center. Okay. So since this is an SDH, it is eligible to start a lactation management unit, right? Tell the answers at the end. Yeah. So what is the minimum space that would be required for the same? Then third is what are the equipments that need to be purchased for collection and processing of milk in this setting? And can this hospital use the stored milk for other babies if the mother's own milk is not available for the baby due to some reason? Go to the answers. So the answer to the first question was that the SDH can start a lactation management unit as per the national guidelines. Now, this lactation management unit requires a space of somewhere around 160 square meters. If it is a milk bank or a fully functional milk bank or a comprehensive lactation management center, then the space required would be around somewhere 350 square meters. Okay, but for this one, space of 160 square meters is enough. The equipments they need to purchase is a refrigerator, deep freeze, sterile containers, and a breast milk pump. What they do not need to purchase is they need not have a pasteurizer. Okay, because these lactation management units, what they are supposed to do is they will help the mothers in expressing their own milk, and then that expressed milk can be stored after labeling, and it can be used for their babies alone. Okay, so the answer to the fourth question is that we cannot use this milk which is donated by one mother for other babies, because we are not pasteurizing it, we are not doing any bacterial culture on this. Okay, and it is just that we'll help a particular mother to express the milk and store it for her own baby in future. Okay, so that is how these lactation management units are supposed to work. Then coming to the next OSCE. So preterm neonate who is born at around 26 weeks of gestation, the lungs are expected to be in what stage of lung development? So the right answer would be saccular. There is some overlap between the canalicular and saccular, but most of the literature says that by 26 weeks, the saccular phase would have started. Okay. So, I mean, both are correct, but most or more correct would be a canalicular phase. Okay. Sorry, the saccular stage. Then next is a tracheoesophageal fistula usually develops due to a defect in which stage of lung development? Answer to the second question. So the answer is embryonic stage. Okay, because the separation of the trachea and esophagus usually happens in the first stage. Okay, so any defect during that stage may lead to a tracheoesophageal fistula. Okay, so the answer is embryonic. Then a congenital diaphragmatic hernia occurs due to the failure of development of pleuroperitoneal membrane during what stage of lung development? So the answer is actually pseudoglandular or the second stage. Okay. Then coming to the fourth question, a congenital cystic adenomatoid malformation, that is CCAM, usually occurs due to arrest or alteration in the lung development during what stage? So again, for this question also, the answer is the same. That is, it happens during the pseudoglandular phase. Okay, so both the answer for both 3 and 4 is stage 2 or the pseudoglandular phase. And then last question is alveolar capillary dysplasia usually occurs due to an abnormality during which stage in the lung development? Coming to the answers. So the answer to the first question, it can be saccular or canalicular both. There may be some overlap. So, but most of the literature usually says by 26 weeks, the saccular stage starts. Then next, the answer to the second is the first stage, that is the embryonic stage. Answer to the third question and fourth question both, it is the pseudoglandular stage, and to the fifth is the canalicular stage. Okay. So alveolar capillary dysplasia usually happens due to a defect in the canalicular stage. Okay. Then coming to the fifth OSCE. So again, here a group of researchers, they decide to conduct a study to assess the association between neonatal seizures and maternal diabetes. So, okay, we had a case, the previous case was of that only. So, a group of researchers, they decided to conduct a study to find the association between neonatal seizures and maternal diabetes. Now, they select a group of babies who are born to a diabetic mother and who developed seizures. And then what they did is, of those babies who developed seizures, they compared those babies with the babies of diabetic mothers but not having seizures. Okay, so I think you understood the scenario. So it is basically a study where they took all the babies who are born to diabetic mothers, and of them they selected the group where the babies had seizures and compared them with the group which didn't have seizures. Okay, so the first question is, what is the type of study design? If- So, right, the answer is actually not case control, it is actually a nested case control. Okay, so if you read the question carefully, they have selected a cohort of babies who are born to mothers with diabetes. Okay, so that becomes the first this thing. So they have selected a cohort, that is the babies who are born with mothers with diabetes, and of them the set who developed seizures were compared with those who didn't develop seizures. Okay, so this becomes a nested case control study. Okay, then coming to the second question. So what are the advantages of this type of study design? Okay, so since this is a nested case control study, so what are the advantages? And the next question is, of course, what are the limitations of the nested case control study design? I'll tell the answers at the end. And coming to the last question, that is, uh, how do you express the effect size in this type of study? One of the limitations I think someone has mentioned. Okay, and how do you mention the, or how do you measure or express the effect size? Okay, I'll tell the answers. So as I told you, it is a nested case control study design. The advantages are that it actually decreases the selection bias. Okay, because you are already not comparing it with babies who are not born to diabetic mothers. Okay, so since your topic of interest is the babies who are born only to diabetic mothers, it actually reduces the selection bias. It increases the efficiency and it is more cost effective, because if you're going to study it in the entire population, it would be difficult. So now you have a cohort of babies who are born to diabetic mothers, and you're doing a study in only those. So it is more cost effective. There is increased efficiency and decreased selection bias. But at the same time, there is decreased precision and power of the study, because it is a subset of a big cohort. Okay, so the precision or the power of the study has decreased. It does not reduce other biases such as a recall bias, because now you have to go in past and inquire what were the risks associated. So there may be certain recall biases, and it relies on the past data. And of course, the statistical analysis becomes a bit more complex. Okay. And the effect size is usually, as in other case control studies, it is measured in this, it is usually expressed as odds ratio. Okay, so the ratio or odds of event which is occurring in the exposed group as compared to the non-exposed, right? Then sixth OSCE, that you match the following trial or study names with their intended outcomes of interest. Okay. So these are the five. Sorry. So these are the five outcomes. Okay, and you have to match the numbers with the alphabets as to which name corresponds to the study outcome of interest. Okay, so one is correct, that so the answers are the child study is actually the impact of hypoglycemia on neurodevelopment. The detect trial is for PDA. Okay, so it is for the answer for two is D. That is whether early administration of indomethacin within 12 hours of life improves the PDA outcome. The point trial is premature infants in need of transfusion. Okay, so it is the answer for three is E. That is comparing low transfusion threshold as compared to high transfusion threshold for ELBWs. The PIPS trial is probiotics in premature infants. Okay, so that is about the first one. Okay, four. The answer for four is A, and for the fifth one, it is uh, this thing, oxygen saturation targeting. Okay, so boost trial is for oxygen saturation targeting. That is five. It is C. So these are the answers. Okay. Then coming to the next OSCE. So AKI in neonates. So as per the KDIGO, what are the criteria for labeling AKI in a newborn? There are two criteria. One is the creatinine, and second is urine output. But what are the criterias? I mean, we want the specific answer. Then second question is, what is the stage of AKI in a neonate, uh, in whom the baseline creatinine rises from baseline creatinine of 0.4 now rises to a current serum creatinine of 1, and along with that there is a slightly reduced urine output. So what is the stage? So it is stage 2. Right. Then name two drugs which, when taken in the antenatal period by mother, may be associated with AKI in the neonates postnatally. Yes, so one is AC inhibitors, and the DASH is a recent large multi-center study to find the incidence and outcomes of neonatal AKI. And also mention the criteria to start renal replacement therapy in newborns. So coming to the answers. So answer to the first question is that there is an abrupt reduction in the renal function in a neonate with an increase in the serum creatinine of more than 0.3 milligram per deciliter from the baseline, or more than or equal to 50% from the baseline, and also urine output which is less than 1 ml per kg per hour in the last 24 hours. Okay. Then the answer to the second question was stage 2, which most of you answered correctly. The two drugs which are associated with AKI in newborns is one is enalapril and second is NSAIDs. Indomethacin, if they are taken by the mother, it may be associated with this thing. Then the multi-center study which was published recently about the outcomes of neonatal AKI and the incidence is Awaken study. Okay, and last is the criteria for renal replacement therapy. So either it is anuria, or if the most important criteria is definitely anuria, or if if there is hyperkalemia with hyponatremia and volume overload, metabolic acidosis, hypocalcemia, hyperphosphatemia, or maybe inability to provide adequate nutrition due to fluid restriction. Okay, so any of these criteria, if it is fitting, the child may go for renal replacement therapy. Okay, and then coming to the last OSCE for the day. So indication for using this drug in the NICU. I'm sure many of you would have used it. Okay. Then what is the mechanism of action of this drug? How does diazoxide act? And what is the dose for use in NICU? What are the expected side effects while using this drug? And fifth is which drug may be used along with this drug to decrease the side effects? So one is fluid retention. Yes. What else? Okay. So last answer is correct. That is hydrochlorothiazide. Okay, I'll go on to the answers. Okay, so sorry, it is a typing mistake. It is mainly used for hyperinsulinemic hypoglycemia or refractory hypoglycemias. Okay, and the mechanism of action is it acts by opening the potassium ATP channels and allowing the efflux of potassium, and thereby it actually prevents the membrane depolarization. Okay, the dose we usually use is 10 mg per kg per day. Some literature says you can go up to 20, but most of the times it is 10 mg per kg per day, 8 hourly. Okay, and the expected common side effects are hypertrichosis, hyponatremia, fluid retention, but rarely in some SGN units, it has been reported that it may cause pulmonary hypertension. And so it has to be used with caution, especially when you are using it for sick neonates who are at higher risk of pulmonary hypertension. This has to be used with caution. Yeah. And using thiazide diuretics like hydrochlorothiazide may actually reduce the fluid retention and chances of pulmonary hypertension. So I think this is it for the day. If there are any questions, I will be happy to answer.